Hello everyone, and welcome to this live webinar from Springer Medicine. Today the spotlight is shining on breakthroughs in bladder cancer care. I'm Natalie Wood, I'm Clinical Director at Springer Medicine, and I'm really excited to be hosting this webinar today, and I'm delighted to have you all with us. Before we move on, I'd just like to acknowledge my colleague Shreya Nanda, Senior Clinical Content Manager in our team. Unfortunately, Shreya couldn't be with us as planned today, but it's very much thanks to her efforts that this webinar is happening, because she's the one who looks after the oncology content that we commission and share on our platform. So for those of you who have joined us before for one of our webinars, it's great to have you back. And for anyone who's new to our platform, we are an international medical education site, and we cover a breadth of clinical specialties. So we provide cutting-edge clinical education for specialists in a variety of formats, which we highlight in our regular editorial newsletters that we curate just for you. Turning to the topic for today's webinar, bladder cancer management is undergoing one of the most notable periods of change in decades. New clinical data, emerging therapies, and advances in biomarker-driven decision-making are reshaping how we think about treatment selection, sequencing, and safety, and long-term outcomes. The evolving landscape brings exciting opportunities and practical challenges. As novel agents enter clinical practice and treatment pathways become more personalised, it's increasingly important to understand not only what the latest evidence shows, but how these developments can be applied meaningfully in day-to-day patient care. Today, we are extremely fortunate to have two internationally recognised experts with us to focus on two key areas of change in bladder cancer care. First of all, Professor Guru Sonpavde from the Advent Health Cancer Institute and University of Central Florida in Orlando in the US will provide us an update for us on the management of non-muscle-invasive bladder cancer, including evolving treatment approaches, recent clinical data, and considerations for patients with high-risk or BCG-unresponsive disease. And we are then going to hear from Professor Axel Merseburger from University Hospital Schleswig-Holstein in Lübeck in Germany, and he's going to discuss advances in muscle-invasive bladder cancer, including developments in perioperative treatment, patient selection, multidisciplinary care, and the growing role of biomarkers. As a reminder for you all, here are the learning objectives for the webinar. By the end of our time together, we hope you'll have a clearer understanding of the latest clinical data, key safety considerations for emerging therapies, and how evolving biomarkers may support more tailored treatment decisions. Without further ado, I would like to hand over to Professor Sonpavde. Welcome and thank you so much for joining us.
Hi, I'm Dr. Guru Sonpavde. I'm thankful to the organizers for inviting me to give this talk. So my topic is therapy and advances in non-muscle invasive bladder cancer. These are my disclosures. So coming to some of the clinical picture and risk stratification of non-muscle invasive bladder cancer, as most of you might know, this is the most common way bladder cancer presents. The vast majority of bladder cancer presents in the non-muscle invasive stage. And we think about this mostly in terms of risk of disease, very simply put, low risk, high risk, and an intermediate risk. And there's also a very high risk disease. And we look at the staging and look at the T staging on the right-hand side in the figure, you get a sense of some of these stages. So really, quite simply, the low-risk stage is a single lesion. It's a low-grade TA lesion and less than 3 centimeters in diameter and no carcinoma in situ. And as you can see, the high risk is NECIS, high-grade disease or T1 disease, which is lamina propria invasive, or if there are multiple or recurrent tumors or large tumors more than 3 centimeters. And there is also a very high-risk disease if it includes other high-risk features like LVI, lymphovascular invasion, and some of the histologic subtypes, which are more aggressive, mentioned there, and a combination of these factors. And now, just looking at the risk stratification, the EAU uses a simpler risk score based on these tumor features I just mentioned. The NCC and AUA integrate more patient-specific factors. Age, older age is worse, comorbidities, prior treatment, in addition to tumor pathology. Now, coming to treatment of high-risk non-muscle invasive bladder cancer, this is a disease that undergoes treatment by the urologist initially, of course. There is the transurethral resection of the bladder tumor, and this is followed by potentially adjuvant intravesical therapy, which depends on the risk of disease. For low-risk disease, essentially a single dose of perioperative mitomycin C or mitomycin gel is given when necessary. And then there is an intermediate and high-risk disease, the higher risks of disease, where patients are considered for a repeat TU or BT to resect any disease that may have not been fully resected. And this is followed in high-risk disease and some intermediate risk disease with BCG induction therapy, which is weekly times 6. And then there's a maintenance given for 36 months based on the evidence from the SWOG 8507 trial. And the way this is given is weekly for 3 intravesical installations, which is repeated every 3 months, twice, and then it tapers out to every 6 months, all the way up to 3 years. Now, the reality is that most patients don't end up getting the full 3 years of this. They kind of get tired of this or tolerate it poorly, and usually it might actually end at 1 or 2 years. That's the usual experience in the clinic. Now, these patients will undergo surveillance cystoscopies, including upper tract imaging and urine cytology to look for recurrence. Now, blue light cystoscopy does detect more disease, but its use has been limited since it's more cumbersome, it's more expensive, but there might be benefits in terms of detecting more disease and more optimal treatment might actually lead to less recurrence. So that is something for the community to think about and study this some more. Now, there is low quality evidence suggesting no clear difference in recurrence for progression with BCG plus interferon compared to BCG alone. Many studies have been done here. So really, we don't have great evidence. So most people, urologists would use BCG alone in this situation. Now, there are some genomic predictors of good outcome or poor outcomes as shown here. Now, these are not in use in the clinic routinely, but as you can see, some genomic alterations in the tumor with non-muscle invasive bladder cancer confers lower risk versus high risk. The high risk alterations are p53, CDKN2A, ARID1A, CCA1 amplification, while high TMB, DDR alterations or ApoBec-A alterations are associated with good outcomes. So this is not being used in the clinic right now. This is something for the community to develop. Now, can we use other biomarkers to guide initial therapy of non-muscle invasive bladder cancer? And this is in the era of BCG shortage. It might become important when you have a BCG shortage issue. As we all know, there has been BCG shortage from time to time, quite consistently over many years, which hopefully we're solving now. So AI-based computational pathology has been examined. Essentially, there was improved prognostication of BCG-treated NMIBC independent of clinical pathologic features. So this is histopathology undergoing computation analysis, looking at many features of the pathology, which an ordinary human eye cannot see. And really, this was a major prognostic factor. But what's unclear is it was prognostic in the setting of BCG, but it's not clear that if we have poor prognosis on BCG, will something else have made a difference in this patient? So this does need further study. Now, in the real world, what we know is that of patients who receive first-line BCG, only around half of the patients are receiving adequate BCG, as defined on the left-hand side. And when you look at patients who recurred after first-line BCG, this occurred in 23% of patients with adequate BCG and 32% of patients with inadequate BCG. So obviously, giving adequate BCG for first-line therapy is kind of important to prevent recurrences. What we do know is if we reduce the dose or if we reduce the intensity of dosing, it can compromise, it can negatively affect outcomes as shown in these couple studies here, which looked at either 1/3 of the dose for 1 year, and the other study down there, the Nimbus study, looked at the standard 15 installations over 1 year versus 9 installations over 1 year, and actually showed that there was some negative impact of this, reducing the number of installations over 1 year. What about the impact of BCG strain? So given that there was a huge BCG shortage issue of the TICE BCG, this study was conducted by the US intergroup NCI intergroup system, which looked at the Tokyo 172 strain versus the Thai strain of BCG. And essentially, the end of the day, in this randomized comparison, the Tokyo strain was non-inferior to the Thai strain in terms of outcomes, as you can see. Now, the grade 3 and 4 adverse events were slightly higher with the Tokyo strain. They also, in this study, looked at priming with BCG vaccination, but basically that intradermal vaccination to improve the immune response, that did not seem to have an impact, although PPD conversion also was not prognostic. Now coming to a different state of the disease, this is BCG unresponsive non-muscle invasive bladder cancer. So this is patients who are highly refractory to BCG, and these patients are conventionally offered cystectomy. And so if you look at this, the way BCG unresponsive disease, NMIBC, is defined is as shown at the top. So if you have persistent or recurrent high-grade T1 disease within 3 months after starting BCG, that's unresponsive disease. And if you have TA T1 recurrence within 6 months, or if you have CIS within 12 months after the last dose, after adequate BCG induction and maintenance, that's also BCG unresponsive disease. And the US FDA actually has allowed approvals based on the durable CR rate from non-randomized trials, given that this is a highly unmet need population. So really the guidance from this FDA in the many years ago was that if the lower bound of the 95% CI excludes a 20% durable CR rate, that could be clinically meaningful in a non-randomized study. Now, what we know is that patients prefer to avoid and delay cystectomy, and in this study that looked at the patient's preference, really almost 90% of patients would not choose cystectomy if they have BCG unresponsive disease. So really, there was a huge unmet need for discovering novel intravesical therapies or systemic therapies for these patients who had BCG unresponsive disease. Now, one of the regimens that has been used in the clinic quite often is this intravesical installation of a combination of gemcitabine and docetaxel. In this retrospective study of BCG unresponsive disease, the investigators examined additional BCG, which was thought to be a reasonable community standard, and another group of patients that underwent gemcitabine and docetaxel combination. And as you can see here in this study, there was a higher PFS and CFS in patients receiving gemcitabine docetaxel. So somewhat promising study, again, not really a prospective randomized trial, but promising outcomes in this comparison for gem docetaxel versus BCG for BCG unresponsive disease. Now, there was, interestingly, there was a lower incidence of lymph node positive disease at the time of cystectomy in the BCG group. So that's interesting, but that was kind of a secondary outcome that was done in a small subset. Now, there is another trial called the CYSTO trial, just to highlight the other aspect, the opposite view that maybe cystectomy is quite reasonable in these patients who have BCG unresponsive disease. So this is a study in which the bladder sparing therapy with various regimens like intravesical gem-doce, BCG, pembro, and others were looked at, and the other patients, 199 patients, selected cystectomy. And the interesting fact in this CYSTO study was that physical function was worse in the cystectomy group early at 3 months, which you might expect after cystectomy, but by 9 months, there was no difference between the arms, so intravesical therapies versus the cystectomy arm. The cystectomy was associated with better emotional function, quality of life, and financial burden, and lower depression and anxiety, while bladder sparing therapy was associated with better bowel and sexual health. So really, cystectomy does have some pros associated with it compared to intravesical therapy. So this is something to keep in mind when you discuss these options of intravesical therapies versus cystectomy for BCG unresponsive disease. Now let's get into some of the new agents that are out there now for BCG unresponsive disease and beyond. So this is pembrolizumab given intravenously, systemically, for BCG unresponsive NMIBC with CIS, I should say. So in this study, this is a non-randomized study of close to 100 patients. As you can see, the complete response rate was 41% and the median duration of complete response 16.2 months. And so these data actually led to US FDA approval of intravenous pembrolizumab for BCG unresponsive non-muscle invasive bladder cancer. There are some attempts to also look at other novel combinations of intravenous immune checkpoint inhibition plus intravesical and other therapies, as in this ADAPT bladder study. In this cohort here, the combination of durvalumab intravenously plus intravesical gemdosi had a high CR rate of 89%, and many of these CRs are still ongoing. Now, coming to if intravenous PD-1 inhibition is active in BCG unresponsive disease, why not test it in the non-muscle invasive first-line setting in combination with BCG? So the first trial came out was this CREST trial, which looked at BCG induction plus maintenance alone or combined with sasanlimab, which is a subcutaneously given PD-1 inhibitor. This was in high-risk BCG naive NMIBC, and this was a heterogeneous mix of high-risk NMIBC, including CIS as well as the non-CIS high-risk groups like high-grade TA and T1. And this study was positive for the outcome of event-free survival. As you can see, the hazard ratio is 0.68. And there was some hint that maybe the CIS group is benefiting more. They also looked at the PD-L1 expression to look for whether this could predict patients who benefit from the addition of sasanlimab, but there was actually not a predictive value for PD-L1 expression. Now, at the end of the day, this study is positive, but sitting out there, this has not led to US FDA approval. In contrast, this trial, the POTOMAC trial, did a similar thing, non-muscle invasive bladder cancer, high risk, BCG naive. Patients were randomized to BCG induction plus maintenance, plus or minus durvalumab. In this case, durvalumab was given for 1 year, as opposed to the previous trial, CREST, where they actually gave sasanlimab for 2 years. Now, the POTOMAC trial also is positive with an improvement of disease-free survival with a hazard ratio of 0.68, as you can see. Again, it's a positive trial. And this actually did lead to US FDA approval very recently, May of 2026. When you look at the DFS subgroup analysis in the POTOMAC trial, really nothing clearly sticking out. These are all unplanned, unpowered, not formally powered sub-analyses. And really, there was consistent treatment effects when you look at the direction of benefit in favor of adding durvalumab for 1 year. There was a third trial called the ALBAN trial, which looked at the combination of atezolizumab with BCG in high-risk NMIBC. And the primary endpoint was recurrence, including low-grade recurrences. That was negative. But when they also looked at the high-risk recurrences only, this difference was also not significant, unfortunately. So this study is overall negative for the addition of atezolizumab to BCG in BCG-naive patients with NMIBC. Now coming to the next modality that has led to approval in the US is this agent, nadofaragene. Nadofaragene is essentially a replication-deficient adenovirus that delivers the interferon alpha-2b gene intravesically. And one of the big benefits of this agent is that it is given once every 3 months. So really very convenient because it's not a very frequently given intravesical treatment. The complete response rate was 51%, and around half of these maintained the CR for 12 months. This was US FDA approved back in 2022. And recently there was an addition or an amendment to their approval where the water bath thawing was now reduced to a 25-minute water bath. So it makes it a little more convenient to give in the clinic than it was before, where it needed a longer period of thawing. Next, moving to this agent called NAI or N803 in the past. This has been combined with BCG, both intravesically, for BCG unresponsive NMIBC. So this is an IL-15 super agonist. So essentially it activates NK cells and downstream T cells also. So this is a non-randomized study done in BCG unresponsive NMIBC. And this is actually the data in the CIS group. So as you see here, CR rate around 70%, and the median CR duration was 26.6 months. So this led to US FDA approval back in April 2024. And then I want to highlight this agent here called TAR-200 based on the Sunrise 1 trial. This is essentially intravesical slow-release gemcitabine delivered via a pretzel-shaped device that is inserted intravesically. And the way this is delivered is once every 3 weeks intravesically for 6 months, and then tapered to every 12 weeks up to 24 months. And so when you look at this data here for BCG unresponsive disease, the CR rate is 82.4%. The median CR duration is 25.8 months. So this actually led to US FDA approval last year, September 2025, and this is now available commercially in the US. So really at the end of the day, we have these new agents that have now made it to the clinic in the US for BCG unresponsive NMIBC with CIS. So this is pembrolizumab intravenously, and all the other three are intravesical, nadofaragene, NAI plus BCG, and the TAR-200. So really we have multiple options to discuss with patients and make a choice. Now, coming to some other novel agents on the horizon, this is the BOND-003 trial, which looked at cretostimogene. Cretostimogene is essentially an immunogenic adenovirus. This is an adenovirus that infects cells that are deficient in the RB pathway, which is a majority of bladder cancer cells, high-risk bladder cancer cells. So really, this has been very promising in the preliminary data here. It's given intravesically weekly for the first 6 weeks, and then there's a maintenance. As you can see, CR rate 75.5%, and at 12 months, 44.6% in CR. Now, this agent is still not approved, and we await further data and potentially approvals in the future. Now, this agent intravesically has also been combined with systemic PD-1 inhibition and looked promising in this kind of combination. Next, moving to an agent called TAR-210. This is similar to the pretzel-shaped device TAR-200 that delivered gemcitabine. In this case, we are delivering erdafitinib, which is a pan-FGFR inhibitor. In this case, TAR-210 was inserted, and this is inserted every 3 months, so very convenient. This is a very slow-release erdafitinib over 3 months. And so when you look at this patient population with NMIBC that had FGFR3 activating mutations or fusions, and remember that around 70% of patients with NMIBC, especially early NMIBC, can have the FGFR3 activating mutations or fusions. So really, phase 3 trials are ongoing based on this very promising initial data for high CR rate and durability of this outcomes with this agent. There are many ongoing phase 3 trials. I want to highlight that in the first line setting, the BRIDGE trial is actually comparing BCG versus gemcitabine docetaxel. So we'll see what happens with that. That trial is completed accrual. And then there's other phase 3 trials which are further examining all of these novel agents I just mentioned in a phase 3 setting as shown here. There are other emerging immunotherapeutic agents intravesically given for NMIBC, as shown here, EG70 looking preliminarily promising. This is a plasmid gene therapy delivering IL-12 and RIG1 genes, and TARA-002 regimen delivers Streptococcus pyogenes bacterium as a kill bacterium, which has shown initial promise. And many emerging intravesical ADC data for disitamab vedotin in HER2-positive NMIBC, given either intravesically or intravenously, and also intravesical EV enfortumab vedotin has been studied in a small study, but this is not being pursued further, unfortunately, but there was promising data in initial small cohort of patients. Now, one of the questions that arises is with all of these intravesical therapies emerging, how many can you give consecutively in patients who are BCG unresponsive? Is there a risk to giving it for too long and too many intravesical agents? So preliminarily, it looks like you have to be careful about going beyond for a very long time with too many lines of intravesical therapies. This study here suggests that the rates of recurrence and progression increase over time, especially in patients treated with additional lines, maybe more than 2 lines. You have to tread carefully because there is a risk of bladder cancer death in patients given these therapies beyond 1 year and beyond 2 lines of therapy for BCG unresponsive disease. Circulating tumor DNA data emerging for prognostic impact. That there can be ctDNA even in NMIBC actually, but if there is ctDNA, it might provoke further evaluations, potentially consider that this could be muscle-invasive disease truly. So this is something that's emerging to risk stratify patients. Urine tumor DNA is emerging to monitor patients dynamically and to potentially escalate or de-escalate therapy based on utDNA disappearance or persistence after initial therapy for BCG unresponsive NMIBC. Bladder preserving chemoradiation has been examined in T1 high-grade disease, and it looks interesting. There is promising data here, but I do want to mention that the distant metastasis rate at 5 years was nearly 20%. So I think careful patient selection needs to occur in these patients, and probably the patients really who are unfit for cystectomy with not a very long expected survival warrant this approach. I will end with this take-home summary slide, which is the latest NCCN guidelines. And I think, as you can see, I just want to highlight that in NMIBC, BCG naive patients, the preferred treatment is BCG, but there are other recommended treatments, including intravesical chemo, Gem-Doce. When there was BCG shortage, people used to do Gem-Doce a lot, clinical trials, of course. Now, in certain circumstances, this is a very recent addition by the NCCN, the combination of BCG induction plus maintenance plus durvalumab for 1 year has been added in this third category of useful in certain circumstances. So not really a preferred or other recommended option, which is interesting. In BCG unresponsive disease, we discussed all of these options. In this, cystectomy still is favored, but there are other recommended options. All of these novel agents we discussed. And then you see the similar recommendations for BCG unresponsive NMIBC without CIS. And in BCG experienced, BCG exposed patients, not really BCG unresponsive, repeat BCG is reasonable, clinical trials, of course, other intravesical treatments, and cystectomy in some circumstances. So I will end right here in the interest of time, and also would encourage investigators and physicians to consider trials whenever possible to expedite advances. Thank you.
Thank you so much, Professor Sonpavde, for taking us through that. It's a really fantastic look at what's happening with NMIBC. One question before we move on. I just noticed, and this is from me because I was noticing what you were saying while we wait for questions to come in from the audience, that you talked about, BCG and the adequacy of the treatment, and that it isn't adequate for a lot, and that it can have a real, can really compromise outcomes. So is there anything you can, when patients are going to receive the BCG treatment, what you can do to try and encourage them to stick with the treatment and stay with it to maintain the outcomes?
Yeah, the data I think are strong for an induction plus maintenance approach based on the SWOG study, and really the induction followed by 3 years of maintenance is how the SWOG study did it. But the trials that I mentioned, the Potomac and the CREST, actually did the same thing. But we try to get up to at least cross a year, but ideally go up to 2 years. Maybe the longer, the better. So I think we should try to replicate data from the SWOG study as far as possible, because the data support that as the better approach for preventing recurrence and progression.
Lovely. Thank you so much. And yes, so now we're going to hand over to Professor Merseburger, who's going to take us through advances in muscle-invasive bladder cancer. Thank you so much for joining, and look forward to hearing what you have to say too.
It's a great honor, and following up Professor Sonpavde, we've been knowing each other since years already in the work in bladder cancer, and I'm very, very happy that there are so many advances in this disease where when I was a resident like 20 years ago, We just had mitomycin and BCG for years, and nothing really happened. And now a lot is happening, and maybe we could discuss this later, how you choose. I mean, you are that fortunate to have a handful more of options in the US available, FDA approved. So how are we going to choose which patient, which drug? Not that easy. Same, it's not so easy for me now to summarize you the advances in the treatment of muscle-invasive bladder cancer. And me, as a urologist, used to do a cystectomy when we had muscle-invasive bladder cancer. Then we learned some years later that there are other options like radiation therapy. And now maybe we are switching and moving towards the field of bladder preservation. So a lot of changes right now. I'm trying to sort them for you to get an overview on the situation. So what will we cover? What will I cover? The challenges, why the outcome after just doing the cystectomy still needs to improve. Then I'm going to look and present you the perioperative therapy, and we are promoting this since years, that perioperative therapy has to be done, if possible, on and available and reimbursed in patients with muscle-invasive bladder cancer. We have the cisplatin eligible situation, but we also have the cisplatin ineligible majority, where we have some more data just recently been published. Then interesting ideas of markers, the ctDNA story, adjuvant treatment with an established standard of nivolumab. This is the data of Checkmate 274, which led to MFS, metastasis-free survival benefit, and overall survival benefit. But we've seen more modern drugs and modern regimens in this adjuvant setting, and I'll show you some data how maybe in the future or already yet ctDNA can guide our decision on how we decide adjuvant or not adjuvant. This topic is very hot, bladder preservation. We are starting trials this summer here in Lübeck as well, with not only trimodality therapy, which is like possible since years or decades, but also now some non-radiation therapy and non-surgical aspects, except the TORB, to treat muscle-invasive bladder cancer. And lastly, I would try to put everything together, mainly focusing on the EAU guidelines, but also bringing in some of what we published in the German guidelines, some practice points. So definitely MIBC is a curable disease, but we still have many relapses. About 50% of the patient relapse after cystectomy alone. We know that 50% are unfit for cisplatin, and we know that there's a 5 to 8% benefit, absolute overall survival benefit, gain from neoadjuvant chemotherapy. A couple of years ago, there are new perioperative standards that are right now emerging. And when looking at the adjuvant trials, what you see is that 50% after 3 to 5 years die of this disease, even in this adjuvant trial design. So we sometimes, as surgeons, when we offer neobladders or ileum conduits and nerve preservation, sexual function preservation, cystectomies, have to realize that bladder cancer is far different than, for example, prostate cancer, where you have a recurrence 10, 15 years later, but very few men die of prostate cancer once it's cured in the localized setting. This is very different in muscle-invasive bladder cancer, where we know that at least half of, when not more, of the patients we operate will die of this disease within the next 5 years. So where do the guidelines stand? And there are differences in the guidelines. The NCCN guidelines differed a little bit from the EAU, from the German guidelines, but they are basically all very similar. So what has changed is that definitely the neoadjuvant and perioperative therapy is really the standard nowadays. If a patient is platinum eligible, cisplatin eligible, offer, that's what the EAU here says, perioperative Niagara regimen with durvalumab. And if it's ineligible, because of the ESMO data last year and the published data by Tom Pauls and the colleagues, showed that in cisplatin ineligible, offer perioperative enfortumab vedotin plus pembrolizumab. And then radical cystectomy with lymphadenectomy remains surgical standard. Aside that trimodality, radiation bladder preservation is also an option in well-selected patients. The German guidelines are going to be updated right now, so mainly copy and paste or somehow like reflecting or mirroring what the EAU published, but we are a little slower from the process. So let's look at the first part, perioperative therapy in cisplatin eligible patients, the data from the Niagara and Keynote B15 trial. Now look at this, Niagara shows an overall survival benefit 25% better, 10% increase of pathologic complete response, and a hazard ratio of 0.68 for event-free survival. That led to approval also in Europe of this regimen. EMA in July 25, EAU recommended this perioperative regimen. Then we have first time combination that has beaten chemotherapy. This is enfortumab vedotin and pembrolizumab in this perioperative cisplatin eligible situation with a hazard ratio of 0.53, 55% pathologic complete response, and an overall survival benefit. And here look at the PCR rate compared to not placebo. This is gemcitabine and cisplatin. So this is active therapy. So this was quite impressive when we saw this data first. So this is a first non-platinum perioperative regimen that surpassed the cisplatin chemotherapy, and this is new after 25 years and a potential new standard for fit patients. So how do we decide how to choose? On the one hand, left we have Niagara with chemotherapy, event-free survival benefit, PCR benefit, hazard ratio benefit, and the known toxicity and the approval status. On the right side, at least in Germany and in Europe, in the cis-eligible, we don't have an approval. In the cis-eligible, ineligible we have, but in this situation as of yet not. But I would say very impressive data. On the other hand, also the skin toxicity and neuropathy, immune-related adverse events needs to be taken into account when choosing the EV-pembro regimen. So it's not an easy answer. The same as Professor Sonpavde just alluded to, we have so many options for non-muscle invasive bladder cancer. So what are we doing with even the majority of cisplatin ineligible patients? And here we saw recent data at ESMO last year, New England Journal of Medicine publication, the Keynote EV303 trial was EFS and OS benefit, a lot of patients, and that led to approval that EV-pembro compared to radical cystectomy alone is much better with regards to event-free survival and overall survival benefits. So this is a new standard. And we've had recent approval from EMA, and so we have this option available also here in Germany. And I think this is something we should offer our patients that are not cisplatin eligible. Another trial, the Volga trial, looking at durvalumab plus enfortumab vedotin plus tremelimumab in the situation cisplatin ineligible. Here, the event-free survival was significant. The overall survival for durvalumab and EV as well, but the triplet not yet significant at the interim. So we will have to see for more data out of the Volga trial. But it's a second chemo-free perioperative option for cis-ineligible patients confirming that ADCs work in this situation. And this is the strategy is really showing in a lot of phase 3 trials now. When looking at the adjuvant situation, let's say we did neoadjuvant chemotherapy, did a radical cystectomy, and what then? What should we give adjuvant? And we have the Checkmate 247 and also the pembrolizumab ambassador data showing a disease-free survival benefit, showing the overall survival benefit for Checkmate 247 for nivolumab, and the greatest benefit is shown in the PD-L1, but all have a benefit. So it's not the label is in Europe. I'm not sure how it is in the US, but in Europe it's restricted to the PD-L1 positive more than or equal to 1%. They have the greatest benefit. So this is one of the standards in adjuvant treatment for this high-risk disease situation after surgery. Here, the question remains, who needs the treatment? And maybe the InVigor 011 trial, which I found very interesting, shown as a late breaker last year's ESMO. The question, can ctDNA decide who needs treatment? In this trial, there was a radical cystectomy and then serial ctDNA testing. And if the ctDNA was positive, adjuvant atezolizumab was given. And if it was negative, there was surveillance in the low-risk situation. So this could be one option in the future. And it was shown that a better survival when the ctDNA showed a clearance due to the atezolizumab treatment in this situation. So this is a shift. The FDA approved adjuvant atezolizumab for ctDNA MRD positive MIBC after cystectomy. I'm very curious to hear from Professor Sonpavde how this is taken up now, if this is readily available, because unfortunately here in Europe, we don't have the test for all our patients. It's really hard to get. So it's not an all-comer situation. So we don't use it in the clinic as of yet, unfortunately, but we want it, I want it, the patients are asking for it. What about bladder preservation? We've been speaking about three-modality treatment since 30 years with TOR and then radiation and chemosensation and so on. So how are we in 2026, so 30 years later? So first, I think it is important to do a maximal TORBT. So we still need urologists, happy to hear that. So best to resect all the tumor. Then if you don't see and best have a complete response, still should do the radiotherapy with a radiosensitizing chemotherapy, platinum-based 5FU. This is depending on the clinic. So in well-selected patients with no extensive CIS, no hydronephrosis, a complete TOR, maybe a solitary T2, trimodality treatment offers comparable outcome, the same as cystectomy for bladder preservation. So in the future, adding immunotherapy to chemoradiation will get investigated more, also with IO treatment, atezolizumab, and so on. And this, I think, requires a multidisciplinary team, good imaging, good biomarkers, ctDNA in the future, maybe urinary bladder markers, and MRI to see how the bladder is in the virus, and cross-sectional imaging of the body, not to oversee any recurrence or lymph nodes that needs to be treated with systemic therapy. So putting it together like a practical algorithm for localized MIBC, and it's not that easy anymore, since personally, if my best friend, and we should treat all our patients as our best friends or relatives, what I offer my patients, I am very transparent with where we stand right now. And even though I'm a urologist, here in Germany, we are involved in a lot of clinical trials. So we are also having the bladder preserving trials now with EV Pembro, very exciting development, and I think it needs to be personalized. The treatment needs to be really, how to say, tailored. So first, we should define, and this is not so easy, what's a platinum eligible, cisplatin eligible. Still, the standard would be perioperative Gemcis plus durvalumab, or if it's available and approved in your countries, EV plus pembrolizumab out of the Keynote B15, followed by radical cystectomy and lymphadenectomy, and then in the adjuvant setting, depending on which study you started with, the adjuvant durvalumab or pembrolizumab. So it's not that easy, and also the patient needs to be informed about the individual toxicities, side effects, or differences on the regimen. I've had some patients that said, okay, I did the Niagara start, and now I want a re-TURB, and I don't want a cystectomy, and I don't even want the adjuvant treatment. I want imaging, re-TUR, and if you don't find a tumor, I want to keep my bladder and stop with everything. If this is the right way to go, I'm not sure. This needs to be tested in large phase 3 randomized controlled trials. Same for cisplatin ineligible. Those are the more frail, the more preconditions patients. And here we now have the perioperative EV Pembro Keynote 905 data, and then radical cystectomy and extended lymphadenectomy. This is the data we have. Not in all countries it's approved for for Europe right now, and I think US as well. So the I don't know, it should not be a green light. Maybe I should mix the colors. It would be more the red light. Be cautious, careful. This is not the standard bladder preservation. I would only recommend it in clinical trials, or if the patient refuses everything else. So it would include a maximal TURBT, chemoradiation, like in 3-modality treatment in selected patients, and it's very important to do strict cystoscopic surveillance. Also, the bladder is not so easy to follow up after radiation. You see the mucosa looks different, so you tend to do more biopsies, which I think is good not to oversee a recurrence. So after surgery, high risk and no neoadjuvant IO before, then, and also if the patient had neoadjuvant chemotherapy, check if PD-L1 allows for adjuvant nivolumab. If ctDNA is positive, adjuvant atezolizumab. This is not the European situation, but I think the US, you have the label, and happy to discuss this. So if it's ctDNA negative, we know it's a better prognosis, and maybe those are the patients where you can spare the adjuvant treatment, also spare cost, spare toxicity, spare the patient going to the hospital. So this is something I think what we need, not only in muscle-invasive bladder cancer, but also in non-muscle invasive. We need more markers that guide our decision in what's the best treatment and how safe we are with maybe preserving the bladder. So the therapies are definitely moving the needle. This is like a schematic own illustration of the respective phase 3 trials. We should not do trial comparison, but everybody somehow does it. So this is just looking at the needle. It should all move to the left, and it does, regardless of the regimen, whether it's a Checkmate 274, Niagara, Keynote B15, all really there's a consistent risk reduction across the independent phase 3 trials. The largest neoadjuvant effect we've seen so far, the most impressive, I would say, was the EV Pembro. The benefit really spans on event-free survival, disease-free survival, and not just response, and even overall survival was prolonged. And also, it's really like impressive, the CR rates we see nowadays with those novel combinations introduced at an earlier time. So for the multidisciplinary team, what does it mean in the clinic? I think we should still assess the cisplatin eligibility early. There's a lot of discussion, some also industry-driven, some investigator-driven. What are the factors, the factors that we can use, and there are known criteria like the GFR, performance status, comorbidities, perioperative pathway. Really assess this with the known algorithms. Treat before. We urologists had to learn this lesson the last decades. Don't do the cystectomy and then see what comes out and then give adjuvant treatment. This is not en vogue anymore. It's vintage treatment. So novel treatment is a combination. If you can't do the chemotherapy yourself, work in a multidisciplinary team. Look out for colleagues that do this, and then they will happy to send you the cystectomies again. And it's for our patients. It's prolonging the life expectancy. So it's very important to give neoadjuvant perioperative treatment. Also, when it comes to earlier treatment with novel combinations like IO treatment or like the ADCs, worldwide, not really a lot of countries the urologists are experienced with. It's mainly just maybe Japan, Germany, Switzerland, where the urologists are giving the ADCs and pembrolizumab. So we really have to manage those side effects. And it needs to be like a very good combination of the teams before the surgery and then coming back to the medical oncologist for the subsequent treatment in the adjuvant setting. Hopefully, ctDNA can be widely used to personalize not only the adjuvant treatment, but also to see maybe this is a molecular marker for residual disease and where the patient really needs adjuvant immunotherapy and who can be spared. I think we have to keep bladder preservation on the table. I think we as a urologist won't be unemployed. There are so many other options, and still there are salvage cystectomies and TURBs. So I think we need to be fair. If the data is out and if it's positive, offer trimodality therapy in suitable patients with within an MDT. And that's, I think, very important. We've seen data that an MDT decision, patients that are presented in an MDT in general live longer than patients that are just treated on the shoulders of one or two experts. So I think it's important that every MIBC patient should be looked at by a multidisciplinary team before the therapy begins. This is like the S3. This is a German guidelines recommendation, which I fully support here. So probably not my take-home messages, because it should be rather be my take-to-clinic messages. I have to admit I was a little nervous speaking after this worldwide known expert, Professor Sonpavde, which I've read multiple books and papers from throughout my career. So I'm very honored to be speaking here with you. And please correct me if there were some major mistakes in my slides. I think there's a lot of changes right now we've seen here in muscle-invasive bladder cancer. We have to integrate nowadays systemic therapy into the regimen with surgery or radiation therapy. We have to look whether the patient is cis-eligible or ineligible. Then there are different options nowadays. We know that adjuvant immunotherapy with nivolumab and also the Ambassador trial has shown the pembrolizumab that it works. Hopefully in the future we have more ctDNA options to really let us direct the patients with this molecular residual disease marker, which are the ones that really need the treatment. And hopefully in the future we will work together to preserve the bladder, because honestly, I mean, tomorrow I have a cystectomy scheduled and I like the surgery. It's good. I'm there 3 hours in the OR. It's a very satisfying surgery for the surgeon, but for the patient, it's a life changer. We know this. Regardless of neobladder or ileum conduit, the quality of life is changed. And this is like something we cannot get back to. This is a lifelong change of quality of life. So if you want to know more, read your national guidelines or the EAU guidelines or the NCC guidelines, ASCO guidelines, ESMO. So I think this is very important, and take your patients to the tumor board. I think that's a fair situation. Some references for you, not to read now, but happy to share my slides. And this is my final slide. And I thank you very much for your attention and hand over to Natalie now for the moderation. Thanks a lot.
Thank you so much. Really appreciate that. It's a fantastic presentation, and I think everyone will have learnt a lot. We've had some questions that are starting to come in. I might just ask you one specific question before we all start chatting. And this question that's come in is talking about the ctDNA performance, and I was going to ask about this because it all seems quite exciting, and you seem quite excited by it. And someone's asked whether stratifying the ctDNA performance by histological subtype could help explain the variability in its diagnostic accuracy after treatment. And then the follow-up to that is, do you think analysing ctDNA according to different histological subtypes might improve its predictive performance?
A difficult question for somebody that has not used this technology yet here in Germany. So I would be happy if Professor Sonpavde chimes in here. So I think we need to my short answer would be the different subtypes, histological subtypes. We don't really have a lot of data. The data we have from the IMvigor trial is in TCC, so not variants. So I don't know the second part. First part of the question, can you repeat it? It was a little bit stuck in the orbit here from the connection.
Oh, I apologise. It was just more talking about stratifying the ctDNA performance by the histological subtype and wondering if it could explain the variability in diagnostic accuracy after treatment. I think they kind of go together.
Yeah, so I think I answered this. I'm happy to hear what Professor Sonpavde says.
Yeah, if we could bring you in, Professor Sonpavde.
Yeah, I think we have used ctDNA for MRD assessment here using the tumor-informed ctDNA here, as you might know. And these studies have been done in the prospective trials, as you know. In Niagara, this was done. We're waiting to see what happens with the EV pembrolizumab peri-op studies with ctDNA data. And of course, IMvigor011, where adjuvant atezo was given or not based on ctDNA and with randomization in the ctDNA positive group. Now, the thing is, all these patients had predominant urothelial carcinoma, and Niagara actually allowed even predominant non-urothelial, but you needed to have a urothelial component. So this is the population in which we have the data. The way I look at ctDNA is, if it's positive for MRD, you're going to have a bad prognosis, because the median time from Signatera positive to clinical recurrence was around 4.5 months if you look at the placebo arm of IMvigor011. So that's really almost like early metastatic disease. If you ctDNA negative, then unfortunately it can be false negative. A single time point can be false negative, 25–30%. If you're continuously ctDNA negative every 6 weeks for 1 year, IMvigor011 tells us that those patients have a great disease-free survival, like 95%. So the way I see it, it's useful. It's especially useful, I think, if you're trying to avoid unnecessary adjuvant therapy in an unfit patient or frail patient. That's where I tended to use it in decision making.
Perfect. Thank you so much. So we've talked about the ctDNA. Another question is coming in, talking about biomarkers and about, are there promising new biomarkers for both non-muscle invasive and muscle invasive bladder cancer, and in terms of helping to guide treatment or monitor outcomes? Are there any that you would sort of like to talk about, mention?
So I think what is more and more important is to look at the biomarkers that are associated with some therapy approval. For example, recently here in Europe, I think America's already advanced with that. Enhertu was approved for HER2 last line bladder cancer, and also what we saw, the EGFR for the TAR 210 device, you need to have a positive marker. So I think the same we have in HRR status in prostate cancer, we will have also in bladder cancer, that we have a marker panel which guide us best with a urinary marker, and also in combination, like cytology is historic but still in use and very good with regards to sensitivity and some specificity, and also in the future MRI to judge the bladder itself, and ctDNA. I think this combination, this would be good to guide, and then maybe with AI to sort out what's the best treatment for the patient. That would be maybe my glass ball prediction.
Yeah, you just actually preempted what my next question was going to be, because everyone likes to talk about AI. It's influencing all aspects of our lives. And obviously, Professor Sonpavde, you had AI on your slides as the point. And I was going to ask how you think AI is going to sort of influence care. And I agree that this seems to be the place where it would fit with the biomarkers, the ctDNA and all of that kind of thing. Is that what you envisage yourselves?
Yeah, I think that computational pathology, to look at histology slides, to discover prognostic and predictive biomarkers, is still emerging. We're not using this in the clinic right now in bladder cancer. But as you know, it's being used in other settings, prostate cancer, it's being used in a specific setting. So I think that this more work needs to be done. One of the benefits of computational pathology is it's more easily globalizable, because you can upload the histology slides and you can do a central analysis at an expert facility. And so actually it has some benefits of reducing the disparities in global delivery of precision medicine. So I think it does have a benefit that way, but there is some need for infrastructure, taking high quality pictures, uploading, but it's that could at the end of the day be cheaper than doing genomics and transcriptomic analyses, which needs bioinformatics and a huge army of people doing this.
Guru, can I interrupt? Could you explain how this works? You scan the slides and send them, or how does it work?
Yes, so that's how this is being done in the prostate cancer situation. We have a computational path to predict benefit from 6 months of androgen blockade. So this is how we're doing it. The slides get scanned and uploaded onto a cloud, and then that undergoes computational pathology and provides a signature for benefit or not. So I would envision this is feasible for most cancers where we have a computational pathology signature.
Yeah, very cool.
That's fantastic. It's really exciting. We've had lots of questions coming in, so please bear with me as I just sort of sort through them. So looking at markers and things like this, someone has asked about the use and function of PDL1 as a predictive marker, especially because there are so many different scoring systems and cutoffs. So I don't know who would like to take that one.
Is it as a predictive marker, or what was the question?
Yeah, so how do you see the use and function as a predictive marker, and referencing the scoring systems and cutoffs and how they differ?
So I think, maybe I start with the indication that there is some from the Checkmate 274 trial, and we always request the PDL1 status in our cystectomy specimen from our pathologist. They do it automatically, because if it's possible, if it's a high-risk situation, in the adjuvant situation, nivolumab after a radical cystectomy has shown a benefit. I've shown this in my slides when the PDL1 is more or equal than 1%. So it's not required for FGFR directed therapies. It doesn't help for the pembro. So I think there are limitations to PDL1. It's heterogeneous within the tumors. It's dynamic over the time. It's influenced by prior therapies. If you give BCG, for example, they're depending on assays and the scoring system. So it has a moderate, I would say, predictive accuracy. So I think there are future biomarker strategies which are more interesting, like TMB, ctDNA. We've discussed on like gene expression signatures, interferon alpha signatures, molecular subtypes. We haven't touched on that, which was very in vogue some years ago, or tumor infiltrating lymphocytes. This is what I would say pops off in my mind when I hear this marker PD-L1.
Fabulous, thank you. So I'm just looking here at some of the questions, and I know, knowing Shreya, something that she might like to talk about, and we often talk about this, we highlight cases, and there are lots of cases of side effects following on from particularly like immune checkpoint inhibitors, all these amazing new therapies. So one question that's come in is whether you think there's like a relationship between the immune-related side effects and treatment efficacy, but also I think in terms of patients, how you go about having those conversations about the possible side effects of these new treatments, especially when you're talking about bladder preservation and what that might lead to on the other side. So I don't know, Professor Sonpavde, would you like to talk about that a little bit first?
Sure. When I discuss immune checkpoint inhibition, and this is usually it's usually PD-1 or PD-L1 inhibitor alone or in combination, I discuss these toxicities as being, potentially severe in 15–20% of patients needing a prolonged course of steroids, and generally non-life-threatening, but can become life-threatening if unrecognized for a long time. So vigilance and early recognition is important. And also the patients need to be aware there is a tiny risk of a potentially lethal immune event, like myocarditis or encephalitis. Is very, very unusual with single agent PD-1L1. With PD-1 plus CTLA-4, that's more common. But I think that overall message I provide is don't self-medicate for side effect, new symptoms, diarrhea, for instance. Report it and have open channels of communication. Early detection and vigilance are critical, and then it's usually quite manageable, most of these immune events. Some patients end up needing lifelong thyroid pills or steroid pills sometimes for endocrine insufficiencies. But those are quite easy to manage, except for the need for the tablet every day for indefinitely. So I don't consider them life-altering necessarily. So most of the adverse events are manageable, except the very severe, potentially lethal ones like the myocarditis and encephalitis, which is unfortunately just bad luck that happens. We don't have any biomarkers for these severe events. That's something that's being studied. So that's how my discussion goes.
Thank you. Professor Merseburger, is there anything you'd like to add?
Not really a lot. I think it's important that to tell the patient that the absence of side effects does not mean like absence of efficacy, and that side effects should never be pursued to improve the response somehow. So we've known, coming back to the question, that some IO toxicities can be like a rough marker of immune engagement and often associated with also good outcome. But this does not always happen. And the same for ADCs. Also, the EV rash or neuropathy may be associated with a benefit. But as said, we can underlie like this lead time bias. This is, for example, to explain patients on longer therapy have more time to develop both response and also immune-related adverse events. So it's a little bit tricky, I would say. So my take home for my clinic is always I look at the response. For example, I have a patient with brain metastasis from bladder cancer, and he has now EV-pembro complete response. And he has some neuropathy, and he still works as a doctor. And I tell them, let's stop. We can always go in, and surely there are colleagues saying, okay, continue. But what's the sense of him not being able to tie his shirt or hold a pen with neuropathy and being cured? So it needs to be like a balance. And I think we can do this nowadays with this very efficacious treatments. Thanks.
Wonderful, thank you. I can see we're getting near to time. I just want to see if I can squeeze in another question because we've had lots coming in. So we have got, there are lots of exciting new treatment options and potential sequences. What combinations or sequences would you like to see in trials? So it's a big question, that one. I'm just squeezing that in. I don't know if there's a short answer to that question.
I'll give you a very short answer. I think that this is probably more of a metastatic disease question, because that's where you first develop these combinations before getting into the peri-op situation or NMIBC, of course. So there's agents being combined, FGFR3 inhibitor being combined with EV pembrolizumab first line. There's also a trial early on looking at sacituzumab combining with EV pembro, and also another TROP2 binding ADC being combined. So several novel combinations. There's novel mRNA coding immunotherapies for neoantigens that are emerging. So really lots of action for new agents and combinations.
Thank you. Professor Merseburger?
Yeah, it's tough, but I mean, this is like an ad board question. So I would say ctDNA status, then markers like FGFR alterations, Nectin-4, TROP2 expression, prior IO exposure, platinum fitness, and the patient goal to preserve the bladder. This would be my short answer.
Thank you. And one more very quickly. I'll do a very quick wrap up. Someone is asking about the radical cystectomy and neobladder, and versus patients who have undergone radical cystectomy only, and looking at overall survival and recurrence rate. Any data supporting that neobladder could facilitate recurrence and spread of disease, which is not something we sort of talked about.
So you mean the question if you get from neobladder more recurrences or something? This is not the case. To my knowledge, this is there's no evidence that the urinary diversion relates to different recurrences. This is I could answer pretty. I would say so. This is quite clear. Or Guru, what do you think?
Yeah, definitely. There's no evidence that the neobladder compromises the outcomes, clinical cancer outcomes.
Maybe the colleague was asking, there's some discussion if robotic surgery with some spread of urine or bladder parts causes more recurrences or local recurrences. This is was under discussion, but also nowadays it's equally with regards to oncologic outcomes to the data that is published.
Perfect, thank you. And just before I wrap up, one last thing, because we like to talk about this, the future. What are you most excited or hopeful about for the next few years? Just a sentence or two, if that's not too unfair. So who'd like to go?
So for me, I start with my German accent, having the easy start. I think de-escalation strategies would be my, because we have potent drugs, but they also have side effects, and not only toxicities, but also financial toxicities where a lot of countries can't afford. And I think here for that, we need to have de-escalation strategies. Thank you.
Perfect.
Well, I would say in my case, I'm novel agents. There's still a lot of things to be done to improve the cure rate, cure most patients with EV pembrolizumab. We've definitely raised the bar, but we still have a long way to go to cure the majority of patients. So there's lots of new drugs, new agents that are looking exciting and promising for the future.
Wonderful. Thank you both so much. So to wrap up, I'd just like to thank everyone for joining us. A very big thank you, of course, to our experts for giving up their time to share their knowledge with us today. We really appreciate it, and I'm sure our audience will too. If you would like to stay up to date with the latest education from Springer Medicine, please do sign up for our newsletters using the QR code that is shown on the screen now. And then other than that, it just leaves me to say that, we look forward to welcome you back another time. But for now, I wish you all a very enjoyable rest of your day. And thank you all again.
Thank you.
Thank you.
Thank you.